It's my pleasure to welcome our participants to today's webinar, titled Utilizing Available Tools for Antimicrobial Stewardship Implementation in Post-Acute and Long-Term Care Facilities, to be presented by Dr. Salman Ashraf. I'm Dr. Marnie Peterson, and I'm the Outreach Coordinator for the Antimicrobial Stewardship Project, which was created and launched back in July of 2016 by the Center for Infectious Disease Research and Policy at the University of Minnesota. We have an expert joining us today for our presentation. Dr. Salman Ashraf is Associate Professor in the Division of Infectious Diseases Department of Internal Medicine at the University of Nebraska Medical Center. You can also see from his title slide, he also serves as the Medical Director for the Nebraska Infection Control Assessment and Promotion Program and is Co-Medical Director for Nebraska's Antimicrobial Stewardship Assessment and Promotion Program. Dr. Ashraf is board certified in internal medicine, geriatrics, and infectious diseases. He's a member of the SHEA Long-Term Care Special Interest Group, the SHEA Education Committee and Infection Advisory Committee of AMDA, the Society for Post-Acute and Long-Term Care Medicine. We're excited to have him here today because Dr. Ashraf is currently working on multiple projects focused on promoting infection prevention and control and antimicrobial stewardship programs specifically in long-term care facilities, and he has a great webinar planned for you today. Just a few words to our participants of instruction. We encourage you to engage with us today by submitting your questions or comments in writing to our speaker via the WebEx chat box that you'll see located at the bottom right-hand corner of your screen. Please submit your questions to all panelists so we are able to address them at the end of Dr. Ashraf's webinar. So with that, I'd like to welcome Dr. Salman Ashraf to the webinar, and I will turn it over to him for his presentation today.
Thank you, Dr. Peterson. Thank you, everyone, for joining. I think we will have a great talk today and hopefully some question answers in the end. What I'm going to start with is a disclosure. I do have a grant funded from Mark, but that's not going to be relevant for the talk today. There is no conflict that I can see for today's talk. What I want to do today is to make sure when everyone leaves the webinar, we have a basic understanding of why we need antimicrobial stewardship in long-term care facilities. And we learn various strategies to develop a formal antimicrobial stewardship program in long-term care facilities using already available tools and resources. And then we'll talk about some of the programs that others have tried or some of the interventions that others have tried and what were their effectiveness and what were their limitations. So we'll go through some of those things also as we go along. So why do we need antimicrobial stewardship in long-term care facilities? All of you are already aware that long-term care facilities are providing more and more post-acute care services. According to American Healthcare Association Quality Report 2013, a typical 100-bed long-term care facility will take care of 189 short-stay individuals as compared to 86 long-term care individuals. Which means that we have growing medical complexity, increasing exposure to devices, wounds, and antibiotics, and high prevalence of multi-drug resistant organisms in our long-term care facilities. Nursing homes are considered to be the reservoirs of multi-drug resistant organisms. In this study done in Wisconsin in 6 different long-term care facilities, the investigators looked into prevalence of MRSA and fluoroquine-resistant gram-negative organisms. And in all 6 facilities, they found significant number, close to 30 to 40% of residents colonized with one of these bacteria or both, in all to all about 38% colonization rate. You can see some facilities are better, some are a little worse, but then everybody has a problem. we also know that long-term care facilities play a role in regional dissemination of multi-drug resistant organisms also. So in this outbreak that was described in 2011 of KPC producing Enterobacteriaceae, there were 42 cases of KPC producing gram-negative organism identified. 24 cases were linked to one long-term acute care hospitals, which is in the dot in the middle, which says A, the red dot. That was the epicenter there. But then 75% of the rest of the cases were linked to 3 nursing homes. So you can see on the left side, the A from the long-term acute care hospital A, patient 21, 23, and 20 were discharged to nursing home B, and then there are so many other nursing home residents then developed the same organism. Those were different than when they came into the nursing home B. So that tells us that there is some amplification going on in the long-term care facilities also. So it's important for us to keep that in mind. And finally, the C. difficile infection is also on the rise. We know that 25 to 75% of residents receive at least 1 course of antibiotic, and up to 1/3 of those treated with antibiotic in long-term care facilities end up acquiring C. difficile infection. The prevalence has been reported to be as high as about 15%. Now, in 2012, a study estimated that a quarter of all cases of C. difficile in the nursing, a quarter of all cases of C. difficile infection in the U.S. were nursing home onset in 2012. So that's important to consider also. So how big is the antibiotic problem? How much antibiotic we are prescribing and for what reason? So 25 to 80% of the antibiotic use in the nursing home over the last 30 years, multiple studies have been done and they found those to be inappropriate, at least 25 to 80%. Depending on study to study, it varies. It varies. Now, when you look at what are the reasons for prescriptions of antibiotic in long-term care facilities, you will see that the most common reasons for antibiotic prescriptions are for either urinary tract, the skin, or respiratory tract sites. 3/4 of all antibiotic use is for these 3 sites. 1 of 3 antibiotic prescriptions that is being written in long-term care facilities are either for prevention or treatment of urinary tract infection. So the urinary tract infection is playing a big role, followed by the skin, respiratory tract and skin infections. And if we look into the urinary tract infection a little deeper, up to 1/3 of the prescriptions for a suspected urinary tract infection in nursing home are actually for asymptomatic bacteriuria, and you don't need treatment for asymptomatic bacteriuria. And this study that I am quoting here tried to look into what are the reasons for prescription being written for asymptomatic bacteriuria. And there were multiple reasons identified. One of them was that the non-specific symptoms that we see in our residents, we interpret it as symptomatic when we see the bacteriuria. And then the ordering of urine cultures for non-specific changes is also a driver for prescription for asymptomatic bacteriuria. And then there is a role of the nurses communicating with the physicians. That also, how the communication happens can lead to prescription that may not be appropriate. And then there is difficulty in eliciting information from our elderly residents, so that also plays a role. Sometimes a physician just doesn't know what to do with those cultures that turn back positive, and they just feel better to be on the safe side and write an antibiotic, which they think is the safe side, although it may not be. You can argue about that. And then there is a concern about liability of nurses and physicians. So all of those things are playing into this scenario. So how to deal with this problem? The CMS came out with the new rules, probably all of you are aware now, that the facility must establish an infection prevention and control program that includes, among other things, an antibiotic stewardship program. And then CDC kind of laid the framework out by publishing the core elements for antibiotic stewardship, which is basically a guidance of how to develop antibiotic stewardship programs. And it has 7 pillars: leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. Now it sounds easy, but the difficult part for a nursing home, for a long-term care facility, to implement these core elements. So what do we need to do to implement all these core elements? And that's where I intend to provide you with some guidance and resources that you will be able to use and implement a successful program at your long-term care facility. So let's start with leadership commitment. How do we demonstrate leadership commitment? What constitutes a leadership commitment? First of all, the facility should have a written statement of support for antimicrobial stewardship program signed by their leadership. They should have assigned duties of antimicrobial stewardship team members. So there should be a team that they assign and the duties should be assigned. There should be a communication regarding expectations of the nursing staff and prescribing providers. There should be a culture that promotes appropriate antibiotic use. So everyone has to be on the same page. That is what leadership has to commit to in order to fulfill the CDC core element requirement for leadership commitment. Now it's hard to put everything together. So our team, the Nebraska ASAP team, working with some other facilities in Nebraska, has been developing some tools that help those facilities set up their program, which you can also get benefited from because these resources are free on our website. So one of those resources is a leadership statement of support, which actually outlines, I'm not going to go on this letter, but this actually outlines the type of things that a leadership has to commit to and sign to. And this, you can use it, modify it, make it your personal letter and can implement in your facility. Now, some other facility, what they have done is that they use the same leadership statement of support that is you are seeing right now and have made it into a letter and send it out to all their providers who prescribe antibiotic in the nursing homes and all their nursing staff and every other relevant person to tell them as an introduction that we are starting this program, this is our commitment, that's what we want to achieve, so that everyone is aware of what's going on. So that's something to think about when you are starting your program. The next core element is accountability. What does that mean? What it means is that you have to empower your leaders of the program. CDC recommends a medical director, director of nursing, or consultant pharmacist to be the leader. Any of them can be leader or co-leaders. I think medical director has to be involved in this program and has to be involved in the leadership of this program if you are going to see successful results, because they will have to discuss with the providers, and the best thing is that if medical director is on board, they can get some other people on board also in terms of prescribing providers. You should provide dedicated time for the ASP team, antibiotic stewardship team, for their activities, including dedicated time for the leaders and for the IP, the infection preventionists, who will support the day-to-day activities of the program. Now, Infection Advisory Committee of AMDA has recommended IPs to get about 10 hours per week dedicated toward ASP activities. That's not a regulation, that's not a requirement, that's a recommendation from the AMDA Infection Advisory Committee. there is a paper that I'm going to refer shortly that has that recommendation if you want to go and look at it. And then you make the team accountable. How you make the team accountable? You make the team accountable because you are providing them dedicated time to do some work. So then you can ask them whether the work has been done or not. You can ask them to set a goal, and you can ask them to report whether the goal has been achieved or not. But if you have not provided them time or resources, you cannot make them accountable also. And then develop your partnership with consultant laboratories, state and local health department. You will need their support at some point of time while you are developing your antibiotic stewardship program. So it's better to have them on board also. And then you develop your team. So who should be the member of the team or member of the committee? For me, what I describe it, I need an infection preventionist on that committee, I need a medical director on that committee, I need a director of nursing or assistant director of nursing, and I need a consultant pharmacist on that committee. Those are the minimum requirements in my mind that you should have on your committee. But then there are other people who can help too, and those are listed there as an optional providers. Now, when you're starting a program, the committee might need to meet more often, sometimes weekly or monthly. But once the program gets settled in and you have a good grip of what's going on, then you can meet at least quarterly and then review the program at least annually as needed. And the third core element is drug expertise. So how do you get drug expertise? So you try to establish access to individuals with antibiotic expertise to implement antibiotic stewardship activities. How do you do that? You can ask your consultant pharmacist. They might be receiving specialized infectious disease or antibiotic stewardship training. There are national societies who are trying to develop training programs to train concerned pharmacists. We are doing a training program for concerned pharmacists also. So the concerned pharmacist can get trained for that. If you are in a network where your hospital in your network have an antibiotic stewardship program, then you may contact their lead to help you out, or you develop a relationship with infectious disease consultant in your community to help you out. One other thing that is not mentioned here but can happen is that the medical director can take some antimicrobial stewardship courses and can develop those expertise too. And there are courses, again, national societies are offering some of those courses. Okay, so those are three administrative core elements where you put your administrative infrastructure in place. Now we're going to talk about those core elements that are interventional. These are the ones where you are actually doing some interventions. So what actions you need to take to satisfy the core element of action? You need to develop some policies that support optimal antibiotic use. You need to think about some broad interventions like algorithms for resident assessment, communication tools, antibiogram use, antibiotic timeouts, or program to prescribe antibiotic for shortest duration needed to treat infection. Any of those can be about intervention. One thing I will say right now, before I go deeper into the presentation, is that do not choose more than one or two interventions at first. You have to choose just one thing and make sure that that one thing gets implemented properly before you go to the second thing. So you have to think about what you want to do, what your use antibiotic misuse in, what area your antibiotic is getting misused in, and then you try to focus on that area. There can be some pharmacy intervention. The pharmacist can help with monitoring adverse reaction, review of lab culture, review of appropriateness of antibiotics. They can help with some of those things. And then you can develop some infection and syndrome specific intervention also. So if asymptomatic bacteria is the problem, then you can develop an intervention, just focus on that part at beginning. So this is the paper that I was talking about that refer for 10 hours, that asks for 10 hours per week for IP time. It has a whole policy template. You can easily find it by even Googling this paper. It outlines the goal of antibiotic stewardship program, structure and procedures of the Antimicrobial Stewardship Committee, along with the responsibilities of its members. So you can use this policy template to develop your own policy. It's a big document, but you can use it and try to develop your own policy. Now, we have helped some facilities to develop policy also, and some of them wanted a brief policy statement rather than a big one. So we kind of condensed that. You can find this brief version of antibiotic stewardship policy on our website, Nebraska ASP website, and you can modify it based on what you want to have in your own policy. But it gives you kind of what kind of things is needed in that policy template. Now, as I mentioned, that there are some things people have tried before and reported in the literature that helps us to decide what kind of intervention are going to work or not. And these are the list of some of the interventions that have been described in the literature that people have tried. And I'm going to briefly go over these interventions and kind of let you know where you can get help from. So Mark Loeb and colleagues worked on introducing an algorithm to help decide when to treat urinary tract infection or how to assess urinary tract infection, and another algorithm to decide when to send, how to interpret the urine cultures. So if you see that algorithm, what they did was they developed these algorithms and then educated their providers, nursing staff, on these algorithms, how to use it. Sometimes one-to-one sit down with a physician and they told them what to do and how to decide when to send a urine culture or when to start an antibiotic, all those kind of things. When they did that, they noticed a 31% decline in antibiotic use for the next 1 year, for the 12-month period. Now, what you will also see on that figure is that the intervention group, which was better than the usual care group, they both start to come together towards the end of the intervention. So the antibiotic use was not as different in the intervention group as the usual care group 12 months down the road. The reason is, most of the time what happens with education is if you don't do it again and again, the effect fades away, and it's probably what was going on there. Another group of researchers tried to do the same kind of approach, and they found that their intervention was producing results even 30 months down the road. And the reason was that, in my mind, that they were using semi-annual educational sessions. So every 6 months, they were doing education sessions again and again. And then they were also going to the providers who needed a little bit more coaching and doing a direct feedback one-to-one, telling them that you are using, you are the higher user of the antibiotics. And that's, you should be aware of that, and this is what you need to do type of things. So moving from the algorithm now to coming to a kind of communication decision aid tool, which we commonly known as SBAR also, SBAR tools. What these kind of tools do is they provide a visual checklist, as you can see here. They provide a visual checklist of what a nurse needs to look for when, let's say in this case, trying to decide if somebody may have a urinary tract infection, and before calling the physician for an order, she looked at all these symptoms and see whether there is the symptoms or not, the symptoms is there or not. And then once the checklist is filled out, then down below what you are seeing is that there is a decision aid tool which tells you, based on what you checked, whether your protocol criteria are being met for a UTI diagnosis or your protocol criteria are not being met for UTI diagnosis. So now when the nurse is calling a provider, he or she can talk to the provider and say, Mr. So-and-so has some confusion today, and I checked all the symptoms, but they're not meeting the criteria for urinary tract infection as of this point. However, it looks like they might need more observation. I will check. I will be okay with checking vitals every 4 hours or so, and hydrate the patient every so hour and so. If you are okay with that, let me know. And if I see anything different, I will call you and let you know. So if you approach a provider with that kind of full history and full plan, the provider is more likely to be confident that you know what you're doing and will go with the observation kind of route rather than just giving antibiotic for everybody. So that can work. So what you're seeing in the figure here is that those facilities who utilizes this tool at least 25% of the time saw a decline from 73% antibiotic use for asymptomatic bacteria to 50% antibiotic use for asymptomatic bacteria. Now, if they have utilized even more, they probably would have seen more benefit. But those facilities who did not use the form, their use did not change. So that tells us that this is an important tool that can help. Now, AHRQ has developed tool for urinary tract infection, SBAR, tool for skin and soft tissue infection, and tool for respiratory infection. I don't recommend that you use all the tool at once. I will recommend that you use one at a time and make sure that that tool, people understand it. You will have to do some education and then go to the next level. There's another tool that we developed based on the SBAR tool, just because some facilities wanted a one-page form instead of a two-page form that AHRQ had. So if you are in a similar situation and you wanted to use one page instead of a two-page because you have to fax it to provider or things like that, you can use that also from our website. Education, providing education to nursing staff about guidelines and providers about guidelines, that works too. This is a study that was done in Sweden, and that's exactly what they did. And they saw a decline in antibiotic use overall, and wait-and-see approach increased. However, they only provided us the duration, 3 months effect duration. So we don't know what happened after 3 months. My feeling is that if they have not been repeating the education, they may not see more sustained effect afterwards. It can work, but it has to be sustained. You have to do recurrent sessions. And then another thing is nursing home antibiogram. Bruno and colleagues did a study where they looked into all the antibiotics that were started and found that 85% of the treatment was started without seeing an antibiotic, without seeing a culture result. And when cultures were available, only 32% of empiric antibiotic was appropriate. The rest they have to change once the culture come back because it was not sensitive. So then they developed an antibiogram and provided education to the providers about how to use the antibiogram. And then 6 months later, they did the study again, and they already saw an increase from 32% appropriateness to 45% appropriateness. There was not statistically significant, but it shows that it might be trending towards that. Now, most of the facilities can easily get an antibiogram if you talk to their microbiology lab about it. You might even have it in your contract, you just don't know it. And if it's not in your contract, next time you sign a contract, make sure that this is in the contract that they provide you with your facility-specific antibiogram. Usually you want a 1-year antibiogram, but if you do not have, I would say, at least 30 isolates of E. coli, which is the most common organism you will see, then you can ask them to do a 18 months or a 2-year antibiogram to get to that number of 30 isolates so that you can meaningfully interpret an antibiogram. And it can also be developed manually by the nursing home. There are resources that tells you how to do that. I've listed them on this website. You can go to those and find out more information about that. Another thing I mentioned before, trying to contact with your local infectious disease experts, that can help. Robingham and colleagues did this study where they start going to do ID consult in one of the long-term care facility once a week, like a half day a week, and then they were available over the phone for the rest of the week to help them, guide them. And they saw a 30% decrease in total antibiotic use since they started this intervention, and their C. diff rate also went down. So that actually helps too if you have some expert helping you out in your facility. The final thing I want to talk about is, in terms of interventions, is post-prescribing review of antibiotics, which we also call antibiotic timeout. What happened in this study is the researchers introduced two forms, Part A and Part B. The Part A was a form that records all the initial signs and symptom vitals, what happens to the patient, why the antibiotic is being started, and documents everything. And then there's a Part B, which you are seeing right on your screen right now. That Part B then starts talking about 48 to 72 hours have gone by. Let's see the patient again and see what is going on now. Have the symptoms changed or not? Have the symptoms improved or not? Do we need to change the antibiotic? Have we sent cultures that has come back? Is the antibiotic sensitive to the culture if we have started one? And things like that. So if you do that, then you're more likely to find out some inappropriate use and can get rid of the antibiotics that are not even needed. In this study, they decreased their antibiotic use by 10%, but only 57% of the time the form was used. So if they have used more, they probably would have gone down even further. So what we have done is we have developed an S-bar kind of antibiotic timeout sheet for the facilities that we are working with. If they need to implement an antibiotic timeout, what kind of information they will need to do. The nurse can use this tool and assess and report it back to the physician, and then the physician can decide what they want to do. However, again, I will say that be careful on how many tools you implement at one point of time. It's good to know all these tools that are around, but implement it one by one. So if you're starting to use an S-bar tool right now, let's make sure that S-bar tool get implemented the right way before you go on into an antibiotic timeout tool. Okay, so we talk about different interventions that you can think of and you can do, and you saw all the resources that you have for the intervention to implement. Now the next step is tracking. What do you track? So you track some process measure, meaning how and why antibiotics are being prescribed. You track antibiotic use measures, so how often, on how many antibiotics are prescribed. And then you track some of the outcome measures, like what is the rate of our C. diff infection, or what is, how common is adverse drug reactions in patients who are getting antibiotics. So for starters, when you are starting a program, I would recommend to at least look into this. Number of antibiotic starts per 1,000 resident days. Antibiotic days of therapy per 1,000 resident days. You can do this tracking yourself also, and you can also ask your pharmacy to give you those reports too. Again, when you have your negotiation for contract with pharmacy, make sure that that's part of that. And then you might want to look into the proportion of antibiotic starts that are not meeting the Lowe's or revised McGill criteria. You don't have to look into every single prescription, but you can randomly pick some every month and see what your result is. The Lowe's and the revised McGill criteria are standard criteria. There's a checklist on our website if you want to use that to determine whether an antibiotic order is meeting that criteria or not. You can use that checklist from our website. And then you can look into your C. diff infection rate or any multi-resistant organism infection rate and see whether those are coming down when you start to cut down on your antibiotic. So this is at least the beginning part that you should want to do. These are the resources. Okay. So that's where I was saying you can actually track your antibiotic use yourself. Here's an example. Nearly all nursing homes use an antibiotic start log or antibiotic infection start log. Instead of doing it on a paper, if you do it on this Excel sheet, and this is an Excel sheet that we developed, and it is found on our website. These are the links here. There are other templates also. I put down another link for that. You can take a look at both. But if you use, let's say, this one, you can see some of those things are already you are tracking. You are tracking all of those things. If you do it instead of paper on this Excel template, what benefit you get out of it? It will automatically, so you will put those numbers and this will automatically give you these graphs that will tell you what your antibiotic start per 1,000 resident days is, what your days of therapy per 1,000 resident days is, whether the McGill criteria met or not. It will give you this report just by doing that part of the job. Okay, so that will make your job of tracking much easier. And it will, you can see January, February, March, April. So you can see how up and down you are going in terms of your antibiotic use, what are the good months, what are the bad months, and all those kind of things. Some additional data collection that you can think of doing, you should probably consider even doing, is tracking adherence to antibiotic stewardship policies or protocols, because you are implementing some of these protocols as bar tool. You know, how many people are actually doing that? You need to know that too. You need to know that. Otherwise, what's the point of introducing some intervention? And how many people are documenting dose, duration, and indication when they write the antibiotic order, right at the beginning, not like when you prompt them. So those kind of things you have to look into. Antibiogram, as I said, you should probably try to get it. So this is an example of antibiogram. The problem with antibiogram is that you can get it from the laboratory. It can be very dense, and providers may not even know what to look for into that sometimes. So you make it simple. So in this example, if you see the E. coli is the most common organism, and if I have to choose, if I don't know what the patient has grown in the past, or we don't have a recent culture result from the patient, and we have to choose an antibiotic for a possible UTI, but we don't really know anything about that patient's previous history or previous culture results, or he never had one or she never had one, we can use something from this table, correct? So I will use probably nitrofurantoin, which is 99% sensitive, or maybe trimethoprim sulfate, 76% sensitive, but I will not use ciprofloxacin or levofloxacin, which is 58 and 59% susceptible. Now, if you get a culture result back and that is sensitive, that's a different issue. Then you don't use antibiogram, then you use the culture result. But at this point of time, when you don't know, you can use that. So this summary that you see down in that tells the physician how to use this antibiotic. The way I'm telling you right now, that's how it tells the physician. So it's available on our website. You can try to use it, and when you get your antibiogram, you can match it up in a way that that it becomes simple for your provider when you send it out to them. And then the next part is reporting. Once you track it, you have to report it to somebody. Okay? So antibiotic stewardship team is a part of the infection prevention and control program. And it will report progress to quality assessment and insurance committee at least annually. So those are the requirements. And then the CMS rule mandate the infection prevention control program to be reviewed at least annually. So antibiotic stewardship programs should be reviewed at least annually. But in addition to reporting it to the quality assurance committee or copy program meetings, this should also be developed for there should be a report, either the same report or a modified report developed for a frontline staff and prescribing providers. They need to know what, if they are working on trying to get the antibiotic use down, then they need to see a quarterly report of where we are. they need to see how much benefit, how much work they have put in, and what is the result of that so far, or what the barriers are and how they need to improve on. They need to know that too. And when you have the facility antibiogram, you need to provide it to the prescribing providers also. So reporting is not only to the quality assurance committee, the reporting is to your antibiotic stewardship committee and to your providers and to your nursing staff. Everybody should know what's going on. And also think about written feedback on antibiotic use for each provider. But I will put it for a later time period. I will not start on a program with providing a feedback right away to the provider. You are using the most antibiotic. They might not like it upfront kind of thing. But once you have the program in place, then you start tracking them down. This is a sample antibiotic use summary report that you can fill up things in there, basically using the Excel sheet that I just talked about. And then you can bring it to your antibiotic stewardship committee meeting and can discuss what are our top 3 antibiotic use, what are the top 3 reasons for antibiotic being used, where we need to focus on in the next 3 months and the next year. That you can do. So you can get this from our website also. We can give you an example, you can modify it. Finally, education, the last point. So when you develop education, you need to think about what you need to talk in education. So if you're doing education for nursing staff and clinical providers, you need to tell them about why the antibiotic stewardship programs are needed. What are its goals? That's the starting education. And then the responsibility of each group for ensuring its implementation. And then you may even provide them with some tools, list of criteria, the CDC guidance on antibiotic use for different common infections. So those are the type of things you need to provide to your nursing staff and clinical providers. For families, residents, resident family council, you will want to talk to them about the need for appropriate use of antibiotics and the dangers of antibiotic misuse to residents and their families. So you need to educate them on that. And also engage the resident and family member in the antimicrobial stewardship program. So where do you get these educational materials from? So there are tools out there. So Robin Jump and colleague published a study. They developed a course. They did a survey of the nursing staff before they took the course and the survey after they took the course. And they saw that after the course, the nurses' agreement that their role influences whether residents receive antimicrobials also increased significantly. So they are becoming more aware of their role. So that's a good course for the nurses to take. That is free, as far as I know, that is free for the nursing staff to take. And you can find it on the link that I mentioned in here. So that's one way to fulfill the education requirement of the core element, to have your nurses take this course, which tells them about antibiotic stewardship. Another thing that we did for one of our facilities who were having an education day, we made a poster for them to put in their educational program, and they staff it with somebody there, so that people, the nursing staff, even if the providers are there, they can come in and see the poster and ask questions about what is antimicrobial stewardship program, why we need to be doing it. So before they started the antimicrobial stewardship program, we kind of introduce everybody by using this poster. This is available on our website. You can download it and make it your own poster. Perfectly fine with that. Okay. And then there are some additional resources. So on our website also and some other websites, what I did was I just listed all these websites that has some educational material. Some are for providers, some are for nursing staff, some are for family and residents. All of them are there. You go to this website, you can find a ton of information about how to educate people, and then you decide what you want to use or what you don't want to use. There are some additional resources again. And I'm pretty sure you will have access to these slides later, so you can find all these links. So in conclusion, implementing antimicrobial stewardship program in long-term care facility is a team effort. there are pros and cons for each of the intervention that have been studied, as we discussed. Facilities will have to decide which approach works best for them based on what their problems are. But one thing you know that you have to have the 7 core elements in place. Now, which part of the intervention you choose, that you will have to decide yourself. The CDC core elements for antibiotic stewardship has to be followed in a successful program. And then free resources and tools are available to help facilities implement various components of core elements. As I have mentioned, there's a ton of tools on our website. There's other website that I've shared in this presentation that you can go on and get some information. I think I will conclude here. This is the snapshot from our website. If you go on to asap.nebraskamed.com, you will see this. There is a save the date. You will see a message there of save the date, June 1, 2018. That's when we are doing an antimicrobial stewardship summit. If you are close by around us in Nebraska and want to register for this summit, I think that you can do that definitely because this is open to everyone. There is limited capacity, so if you want to attend this seminar, you may want to do it sooner than later. The other thing is that it is good for physicians, it is good for medical directors, it is good for infection preventionists, it is good for nursing staff, microbiology personnel, pharmacists, anybody who's involved with developing antimicrobial stewardship programs or improving antibiotic use. There will be a ton of education, national speakers, local speakers, and ton of resources that we'll try to share during these presentations. So that's one thing that you may want to consider if you are around us. And I will take questions now. Thank you.
Great. Thank you, Dr. Ashraf. That was just fantastic. I think highlighting all the tools that you have available. I actually also included the link in the chat box for others to be able to go and access such a plethora of tools that you have created with your team. It's just phenomenal. I guess I'll just start off and before I start, with our participants that are on right now, please submit your questions. If you have any questions for Dr. Ashraf, now is your time. Or if you want to share an experience with him, he's clearly an expert in driving the field forward. I have a question. I think, I'm thinking about people that aren't as far along as you are. Do you provide any, in addition to these tools, do you ever provide any consultation to programs as they're onboarding some of these tools and these programs?
So the facilities that are enrolled with us, in Nebraska, we do provide them continued support even after giving them the tool. We do provide them continued support to help them implement these tools, to answer their questions, to solve their barriers. We remain engaged with them. The only issue right now is that the funding that we have, we only cover Nebraska long-term care facilities as of this point. Going forward, occasionally we get questions from outside Nebraska too, and we answer those questions. We do answer those questions. But the funding is set in a way from the state health department coming to us. So basically, our focus on more Nebraska state facilities. We're not doing ID consultation, but we do providing them tools and templates and guidance to build their own program. There are other teams, I will say, nationally, who are involved with providing consultative expertise to the facilities. We may end up doing that in future, but not as of this point. If we see a big need of that, then we might start looking into that. As of this point, we're trying to help facilities build their own program.
Okay, that's excellent. Well, thank you.
Yeah, but if somebody has a question and they reach out to us from anywhere in the country, we answer.
Absolutely. So any of our participants could email you with a question.
Yeah.
I think getting enough support, not only time, financial support from the administrators, what it would really take to provide a good program is probably a challenge, maybe for some people. What are some of the conversations? Obviously, you probably meet with administrators as you report on your results. What are some of the items that you cover with them, or do they have concerns? I'm just curious as to how you approach the decision makers, administrators.
Yeah. So as we know now that CMS has a requirement. Now, they're not putting financial penalties right now, but they will start soon, that part too. It's just deferred for now, for a little while. One of the things that they have to think into is that if they don't have a good program in place, if they don't have a program in place, they definitely are going to get some citations in that regard. So that's in their best interest, in the leadership best interest to have a program in place, just because of CMS requirement, number one. Number two, what we have also told the facilities, especially the ones that have been dealing with rehospitalizations or the prevalence of multi-drug resistant organisms, that actually then end up causing some rehospitalizations because of severe infections. And then sometimes you don't even have oral antibiotics to treat somebody with and needed IV or IM antibiotics to treat somebody with. Those are costing the long-term care facilities too. Those are financial burden on them too. So it is in the best interest to have a program where we focus on upfront reducing those complications that are about to happen with the antibiotic use. And then that will be a cost of to yes, you will have to spend some additional resources upfront, but then it will help you going forward with your rehospitalization, with your decreased prevalence of multi-drug resistant organisms. It will avoid the situations where you have outbreaks going on in your facility. If you can avoid those things, those are good things, which we know from good antibiotic stewardship program and from good infection prevention activities can be supported. So if you give your time to your infection preventionist and you give your time to your medical director, you can actually see less of those complications.
That's excellent. Yeah, I think that sometimes can be problematic, just getting enough support for the program you need to put in place. I'm curious, this is a more specific question, with the algorithm that you have your staff fill out if they suspect that they had a urinary tract infection. Obviously, a lot of it is based on symptoms. And where does the culture play in? I know that you talked about antibiograms and obtaining culture. So is there obviously you'd like them to follow up within 48 hours, but I'm curious as to where culture plays in because it's not listed specifically on your initial sheet.
Okay, so the cultures are only going to be obtained if a urine culture is only going to be obtained if the resident or patient qualifies for a suspected UTI diagnosis. Basically, you have to have those symptoms that qualifies you to get to have a urinary tract infection before you get the culture. So if your protocol criteria are not being met, then you are not obtaining urine culture or urine analysis. You're only obtaining it when your protocol criteria are met. So basically, the difference is once your protocol criteria are met, the physician can then decide, okay, I want a UA urine culture. They have two options. They can order a UA and urine culture and start the antibiotic right away and wait for the culture to come back. Or if the patient is not very sick, then they can send a urine culture and then wait for the urine culture to come back before starting the antibiotic. But that culture is not even going to be in play until the protocol criteria are met. Does that sound like it?
Absolutely. I'm going in that route, like how frequently you would need the culture, but it seems to me that you go all the way through the protocol first to see if you feel that there are symptomatic, have the disease, and then the culture would be ordered.
Yes, definitely. You go through the whole thing, and then you, in the end, you decide whether you need that or not.
Okay. What do you feel are some of the biggest challenges that you've had? Obviously, your program, how long has your program been in place now?
So we have been in the facilities for over an year now. So almost last year around this time, we started recruiting facilities. So some of our facilities have been with us for almost a year.
Okay.
Yeah.
Did you encounter challenges?
Yes.
Okay. Would you be willing to share some of those? Because I assume they'd be common amongst many of us.
Yes. So the challenges that we see are exactly the one that you are describing about. The time issues, where the IPs are doing so many other things that it's difficult for them to keep track of everything on the antimicrobial stewardship realm. That's the biggest, I think, challenge. Then the challenge are not having getting some difficulty in getting antibiogram from the laboratory. So we have helped them with that. We have talked to the laboratories. We have actually sometime even have gone down to the laboratory and discussed one-on-one with the laboratory personnel and help them get some of the antibiograms that they needed. So, because the system is not yet in place universally, there is some effort that we need to put in. We have started those efforts in Nebraska. So yes, the timing part is one of the most important issues. Then we have the getting the data, from the pharmacy. Again, the pharmacies have to develop some kind of protocol to share those data, and that can be a little bit problematic initially. But I'm sure once more and more facilities will require that, we'll ask them that, then they will have a protocol in place to get those things in place. So I think those are the barriers. The leadership commitment, what we have seen is that at least for our facilities, and most of them are volunteer facilities, so for them, the leadership is ready to engage. Now, they may not be ready to give 10 hours a week right now to an IP to do antibiotic stewardship, but they are ready to give more time than what they have done. Our goal is to get them, to the maximum amount of time that they need. So that's one of the things. The other thing is having these tools, implement these tools. It requires a lot of education also. The SBAR tool implementation requires a lot of education too. So again, we need the time not only from the IPs, but also on the nursing staff time. We need that too. That can be a little bit of problem also in getting implemented right away. But slowly, and so what we are seeing is that slowly and gradually facilities are moving towards that. They get a setback, or they get a CMS visit, and then they have to start doing something else, and then they come back right to us. It's a slow process, but it is moving in the right direction.
That's excellent. Yeah, you mentioned that some people are starting to get those CMS visits.
Yes.
Have you already been visited as well?
So I will not say I have been visited, because our facilities that have been working with us, and we have some different kinds of programs going on right now. So I have heard already that some of the facilities that we are involved in one way or the other, because there are different ways we are involved in the facilities. The facilities who have been visited are actually, the surveyors have told them, oh, you guys are way advanced than what we are seeing. So I think having that binder in place with all the core elements and what you are doing for those core elements, each one of them, and showing them to the surveyors right now that this is what we are doing, is a big benefit to these facilities. At least at this point of time, the surveyors are okay with seeing the type of effort you are providing. Even though if your SBAR tool has not been 100% being used, at least you have introduced it and you have started to work on it a little. They are happy with that. My feeling is that at some point of time, they will start saying, okay, I know this binder, I saw this last year, what have you done since then? How much successful you have been since then? What your antibiotic stewardship committee has decided on to take as a challenge, and have they been able to achieve the goal of reducing whatever your reduction goal was? I think those are the type of things that will come along in future. But for this part, if they have the 7 core elements, they can document how they are implementing the 7 core elements. The surveyors have been very happy with them.
That's excellent. Well, that takes us back to your tools that you provided throughout the presentation today on this webinar. If people can review those and adapt those to their own programs if they don't already have them, it sounds like they would have a very good start. So we are out of time. Dr. Ashraf, and I wanted to thank you so much for this webinar. It's just, it's remarkable how much progress you've made in such an important area. And I'm sure there's more to come. If we had more time, we could talk about the future, so we'll have to have you back. And just to remind our participants that this webinar was recorded and is available on our CIDRAP website for future viewing. And so thank our participants, and thank you, Dr. Ashraf, for your insightful webinar today.
Thank you. Thank you, everyone.